It's my privilege to introduce the next speaker. Sister Vikki Garrick is an inflammatory bowel disease nurse since 2008 from the Royal Hospital for Children in Glasgow, and in this year itself, in 2021, has been made a nurse consultant and has vast experience in managing pathways of care, predominantly with inflammatory bowel disease. Over to you, Vikki.
So I am Vikki Garrick, absolutely delighted to be here. Thank you very much for asking me to come along. And when David asked me to talk about how we would speak about complex patients, how we manage them virtually, I said, listen, I work with teenagers and parents and weans. All of our consultations are complex. So I thought we'd just take a walk through how we deal with our young people. And you'll be able to transfer that into the any potentially challenging consultations that you have. I built it around a case study because that's always the best way, isn't it? I thought we'd start by telling you a wee bit about us in Team Glasgow and considerations and things we have to think about, varying perspectives when we're dealing with young people. You know, what's on their mind, what's on our mind, what do we want to achieve with that. Then we'll get into the nuts and bolts, which are the case study. So the other thing that I was very keen was that you leave here with some practical advice. I am a nurse to my core. I'm all about practical advice. So that's what this is. And again, some of the benefits and challenges that we've come across in having to have our appointments with our young people, and then hopefully some key messages. So this is us in Team Glasgow. I'm a nurse consultant in gastroenterology, but my clinical expertise is in IBD. So we have 6 medical consultants, soon to be more, I'm told. I think we're heading for world domination. One of me, 2 IBD nurses, 1 pharmacist, 1 psychologist, 1 dietitian and 2 surgeons. So we're pretty lucky in terms of the scope of our MDT. The reason I put this slide up here really was this was when I was a clinical nurse specialist. We set the service up in 2006. But I think one of the things that I found quite interesting when I've done this presentation before is clinical nurse specialists have been doing virtual clinics for eons. So anyone in the room with a clinical nurse specialist team, speak to them about it. Because I have to say, when the pandemic hit and everyone had to move to virtual consultations, my experience was we were doing this already. A move to VC consultations was somewhat different, but we were already running telephone advice lines. And my medical colleagues, I felt as if they struggled a bit to get on board with that. Why can't I see the patient anymore? I just thought that was an interesting observation. So we'll now talk about what we do with young people. This is the lovely Gavin after me pulling his nasogastric tube after 8 weeks of exclusive enteral nutrition. Excellent therapy. Please use it on all your young people and old people too. So it's important when we're talking about young people and we're talking about what is this wee person? So in this room here, you have a young person who's trying to find their way. Who are they? Where are their tribe? Do they want pink hair? Do they want blue hair? Lots of other issues with identity and things going on. And then what we do is they have a great big dab of inflammatory bowel disease put on top of that. And then over the course of last year, of course, then we had COVID-19 on top of that as well. So at a stage in their life where they want to be getting out and meeting their friends and becoming who they want to be, everything closed them down. And then subsequent to that, the pandemic also closed them down. And so I think then that takes us to, well, how are we going to manage these people? These young people when they're in the room with us. And I think consultation style is ultimately all about the perspectives of the people in the room. And that was spoken about earlier on today by a couple of really good speakers who were saying, it's all very well for us to be going in with a very clinical perspective. How many times are you stooling in a day? What drugs are you on? When's the last time you had your bloods checked? You want to ask a teenager what drugs they're on, there's never a straightforward answer to it. Normally mum jumps in first. So, I think that, and I still see it in my career now where I go into consultations and it's a very medically, clinically focused consultation. And the fact of the matter is, I focus this on young people because that's my area of expertise, but actually you can apply this to any patient sitting in front of your face. What do they really want? And I'll often start a consultation by that. Hiya, come on in. What's up? What's in your mind? Half of them don't even want to be here, particularly when it's our teenagers. They don't even want to be in the room. And that's been a good thing for moving to virtual consultations because they don't have to come to clinic. But I think thinking about the various perspectives is very important. So here comes a case study. So we have a 16-year-old female, UC diagnosed aged 10 years, so she's had her UC for 6 years, well controlled on oral 5-ASA and a bit of azathioprine, fantastic, but of course, alongside teenagerhood comes varying issues with compliance. So she scoped active disease on rectal therapy, active disease on scope rather, needs rectal therapy, but we've got to do that virtually now. So normally we would bring them up to the clinic and we would say, let me show you this rectal therapy. So this was the first time we actually came across how are we going to do this? The key here is be prepared. That's your take-home message. So what we did was we took it a bit at a time. First thing we did was we emailed the wee person. We've got all of our families on email. A lot of clinical nurse specialist services will have email as well as telephone. So we emailed them and said, therapies are going to change. Let's have a telephone call about that first. So we give them a phone the young person, put them on loudspeaker so the parent's in the room, and we have a conversation about, okay, this is what this therapy is going to do, and I'm going to arrange a prescription for you. That's the other thing we did, proactively arrange the prescription to be with the child, so that then we emailed them the VC link, and when they dialed in to their next appointment by VC, they had their drug, and I had a demo drug as well. And what we did was we brought the young person, they dialed in from just their telephone. Mum and Dad were sitting in the living room behind them. The wee one had the enema there. I had the demo enema, and we just used the camera the way we always would. There was no. The first time I did this presentation, I was imagining, bringing their backside up to the camera. There was none of that. The way that I teach them in the clinic room does not show anybody's backside. There's ways of doing that. But we were prepared ultimately. We were able to demonstrate the practicalities of administration, booked a vigilance call a week later, absolute success. Where we've had problems is, what do you do when you need bloods? In paediatrics particularly, we're really big on height and weight at every clinic. It's, growth outcomes are obviously a KPI for us. What about physical examination? What about perianal examination? What about chaperoning? So these are things we've had to consider, but the kids absolutely love it. They don't need to come out of school. So I've had kids, mum will come up in the car, they jump into the car in the car park with the consultations in the car, absolutely fine, works really well. From a nurse, I really like to be able to see them, so we get to eyeball them, and young people are already really tech savvy. They are absolutely on this. It's interesting when you were talking about help needed for the elderly. I think one of the things that we're lucky with in paediatrics is that our kids are already all over this. They've been doing it forever. So here's the key messages. Plan ahead. So think what's going to happen in this consultation. Obviously, you can't always plan for complexities. Sometimes they just happen. But email or call them first to prepare them for the VC call. We had to do this a lot at the start, and we don't have to do it now. We just send the link and everybody dials in. But it was time invested at the start so that we didn't get a high DNA rate now. Look at the clinic list before the clinic so that you can see, right, is anybody likely to be difficult here? Am I going to see a 16-year-old in her bedroom on the phone alone? Do I need to dial in the IBD nurse for a chaperone? Always consult with the young person directly, not their parents. And I know I sound like I'm teaching my granny to suck eggs, but that really does happen a lot. I see it a lot. The parents are talked to, and the young person is sitting there where it's their disease, it's not their parents' disease. If young people don't dial in, phone them, chase them. It's labour intensive, but it's worth it. Resend the link by text as well, because if they answer the phone, you can say, oh, you're there, I'm just going to text you, dial in the link. Consider the need for a chaperone. Not every consultation can be done virtually, but some of them can. And I think if you have a virtual conversation that doesn't go well, the next thing has to be face-to-face. Otherwise, you're going to lose the rapport. This is my final drum to bang. 10 minutes, it was never enough time to have a consultation with a young person, particularly with parents in the room. I think we need to look at that as a specialty for resource across the piece. Finally, of course, flexibility in approaches is the way forward. Thank you very much.
Thank you, Vikki. We do have time for questions. Are there any questions from the audience present? Dave?
Vikki, I do find virtual consultations difficult, and I think for me it's really easy if I know the patients because I have a relationship with them. It's the new consult. Yeah. Do you have any pearls of wisdom about that?
Do you know what, David? I think that is about connecting with the person as well. Hi, I'm David. You're going to be speaking to me today. This is quite strange, isn't it? We're not used to this. But what we'll do is, and just kind of set the scene and bring them into the consultation as a person. I know that sounds really, but particularly, a lot of people are already quite anxious about coming to see a doctor in a surgery anyway. So I think to address it and say, I understand this might not be comfortable for you, let's give it a bash. If it doesn't work, we'll try and do something else. I think grasping the nettle is what I'm trying to say. I don't know if that helps.
Any other questions?
I have one. What is the process that you use for triaging patients who would be suitable for, complex patients for virtual consultation?
We have, we're very lucky to have quite a robust IBD clinical nurse specialist team who know the patients very well. So what we do on a Wednesday after our MDT is we prospectively look at Monday's clinic list, and we'll say, right, okay, so who's on this clinic list and what patients are likely to need to be seen face-to-face, and who can we phone? And by face-to-face, I mean virtually, I mean using actual VC. And a lot of the time, it's the type of patients who are going to require a bit more in terms of communication or a bit more, dialogue, or if you're having to explain a change in phenotype or a change in drug therapy. These types of conversations often work better when you can see a face as opposed to just hear a voice on the end of the phone. So we triage on a one-to-one, and we go down individually and we see what patients are more likely to need more in the way of discussion. I suppose that's how we triage them.
Thank you.
Thank you very much, Vikki.
Thank you.
Thank you for coming today.